Admiral Gillingham to the hearing here today. I want to thank you for your testimony you're about to give, and I want to thank you especially for your service to this country. Nearly 9.5 million Americans, from private to general, from service member to spouse, from recruit to retiree, depend upon you for health care services that you oversee. Your job is difficult because so many people are depending on you to have the right medical professionals, the right treatments at the right time, because their lives literally depend on it. Over the past few years, the Department of Defense and Congress have made significant investments in our military's readiness. But there is no readiness issue more important than continuing to assure the physical and mental health of the force. Like our witnesses, the subcommittee is committed to doing our part to ensure that the military force we have is as healthy as possible. This means meeting the medical needs of service members and their families at home and abroad. This challenge is even more important as we begin to move past this global pandemic. I would like to know more about how the DoD is moving into the next phase of caring for physical and mental health of our military members and their families, with a particular focus on mental health and suicide prevention. I would also like to hear from you your views on whether the military healthcare system is adequately funded to the issues that you must address. Thank you again for your service, and thank you for your work to better the lives of personnel entrusted to your care. It is an essential part of maintaining a ready force, and I look forward to your testimony. Senator Shelby.
Thank you, Mr. Chairman. And I also want to take a moment to thank our witnesses for being here today. As we move past year 2 of the COVID-19 pandemic, I would like to recognize each of you for your commitment to our service members and the nation as we continue to recover and hopefully move forward. We've expended a significant amount of resources on technological innovation and the delivery of medical services since the start of COVID-19. Today, I'd like to just hear how our dollars, since this is the appropriation, how our dollars have been invested and the lessons that you've learned while combating the virus. I would also like to hear how you intend to apply that knowledge to prevent, if possible, and fight future biological threats. Through medical research, innovation, education, and training, the U.S. military health system remains the global leader in healthcare delivery on and off the battlefield. Maintaining this level of effort, however, will only get more expensive as the competition for scarce resources becomes more acute. To ensure continued excellence, we need to allocate our limited defense dollars only to those efforts, I believe, that directly support and impact our warfighting capabilities. Our military's health system conducts medical research on a wide variety of topics such as cancer, infectious diseases, traumatic brain injury, and burn research, and among many others. Defense funding for these important research efforts have grown significantly over the years, notwithstanding the billions of dollars that this committee, the whole committee, provides annually to NIH to conduct research in many of the same areas. In the 22 Omnibus Appropriation Act, Congress funded an advanced research project agency within HHS for $1 billion. In this year's budget, the President has requested an additional $5 billion for this effort. And while the U.S. medical force and its mission will continue to be a high priority for the members of this subcommittee, the full committee must also ensure that medical research dollars are allocated appropriately across the spectrum. With that in mind, I look forward to reviewing the 23 Defense Health budget and to hearing your testimony today. I thank you for your service again. Thank you, Mr. Chairman.
Thank you, Senator Shelby. We'll start with you, Dr. Smith, for your testimony. You may proceed.
Chairman Tester, Vice Chairman Shelby, distinguished members of the subcommittee, I'm pleased to represent the Office of the Secretary of Defense to discuss the Defense Health Program and its contributions to the health and medical readiness of the department. I'm speaking today just after the formal release of the President's proposed fiscal year 2023 budget, but prior to the release of the detailed J-books. But I'll outline the major activities unfolding in the military health system that will inform our budget proposal for 2023, as well as briefly discuss issues affecting the 2022 execution. In the past year, we've witnessed significant advances in our response to the COVID-19 pandemic, both within the department as well as the department's support of civilian authorities. Lieutenant General Place, the Director of the Defense Health Agency, will provide further details on our COVID response and preparedness for the future. Now, the National Defense Authorization Act for FY 2017 enacted sweeping reforms to the organization and management of military medicine, and we've made significant progress in implementing these reforms. And today, the Defense Health Agency exercises authority, direction, and control over all MTFs worldwide. The same law directed DoD to restructure or realign MTFs as necessary and appropriate to support the department's readiness requirements. Those restructuring efforts were paused on April 2nd of 2020 as a result of resources required to respond to the COVID-19 pandemic, but we clearly plan to restart implementation beginning in the first quarter of fiscal year 23 with a targeted completion in September of 2026. The department's mission requirements in supporting our national COVID response, however, have adversely affected the Defense Health Program budget in FY 2022. Private sector care costs have increased as military medical staff were deployed to support the civilian missions, and other military medical personnel vacancies increased in our MTFs. Our mid-year review is underway, and it will provide a more detailed look at the spending trends we've experienced in the first quarter. At this point in the fiscal year, DHP purchase sector care projections are still somewhat uncertain, as you might expect, both due to the trajectory of the COVID-19 costs and the uncertainty regarding return of suppressed non-COVID care requirements. Despite these short-term budgetary challenges, the MHS continues its sustained decade-long track record of responsibly managing healthcare costs, which remain below the national health expenditures per capita rate. And the department continues to pursue opportunities for greater effectiveness and efficiency by fully integrating the operation of our medical services and streamlining internal operations. The department is grateful for the long-term advocacy and support from this committee for our military medical research program in those areas of most pressing need and relevance of today's emerging threats, which include the COVID-19 pandemic. And in order to sustain this momentum and prepare for future pandemics, our future budget will support pandemic readiness and response in the MHS by enhancing our capabilities to conduct rapid research and medical countermeasure development, such as diagnostics, treatments, and vaccines, while strengthening the capability of the department to quickly identify and characterize new variants and other emerging biologic threats. Our FY 2023 budget will present a balanced, comprehensive strategy that aligns with the Secretary's priorities to include ongoing response to the COVID-19 pandemic, and we look forward to working with you over the coming months to further refine and articulate our requirements. So thank you for inviting me here today to speak with you about the vital role of military medicine in supporting our national security, and I look forward to answering your questions today. Thank you.
Thank you, Dr. Smith, and there will be questions. Next, we'll go to General Place.
Chairman Tester, Vice Chairman Shelby, distinguished members of the subcommittee, thanks for inviting me today to join Dr. Smith, the Service Surgeons General, to discuss the Defense Health Program. I'll add to Dr. Smith's remarks by briefly focusing on some of the critical responsibilities of the Defense Health Agency in support of the military departments and combatant commands. The response to the COVID-19 pandemic was one of our top priorities, vital to the medical readiness of our forces and the health and well-being of all Americans. The department expanded its COVID-19 testing capability and capacity. We currently have 140 operational laboratories for COVID-19 testing, having conducted over 6.2 million tests worldwide. In February of this year, we also allowed military medical treatment facilities to distribute over-the-counter antigen tests for eligible beneficiaries at no cost, providing the Department of Defense with the opportunity to diagnose COVID-19 earlier and allowing our clinical team to deliver treatment in a more timely manner for those who test positive. The Defense Health Agency is regularly updating our COVID-19 practice management guidelines, currently on version number 8, to provide military clinicians and military medical treatment facilities worldwide with a single document on best practices and the latest evidence and guidance across all clinical care specialties. The DHA led a comprehensive campaign to administer COVID-19 vaccines. As of March 23rd of this year, the military health system had administered over 7.9 million doses of COVID-19 vaccines, and more than 1.6 million military personnel have been fully vaccinated. Throughout the pandemic, the DoD provided extensive support to FEMA for COVID-19 response that included both mass vaccination and healthcare delivery augmentation in communities needing additional personnel resources. We also delivered medical support to the Departments of State and Homeland Security for assisting evacuees from Afghanistan. Our medical teams were proud to contribute to this whole-of-government response to both events. In non-COVID activities, the Department continues to proceed with the multi-year implementation of our new electronic health record, or EHR, that we call MHS Genesis. Today, MHS Genesis has been deployed at 66 medical treatment facilities and at more than 1,300 individual locations, with more than 93,000 active DoD users of that system. We'll complete the deployment by the end of calendar year 2023, on schedule. The DHA manages the TRICARE program, and among the most important strategies we pursue is the development of effective TRICARE contracts that deliver high-value, patient-centric care that integrates military and private sector care. The T5 contracts represent the next generation of these contracts. After an extensive multi-year engagement with industry and other stakeholders, the DHA issued the T5 request for proposals in 2021 and is now in the process of evaluating the proposals with our intention to announce award by the end of this fiscal year. Dr. Smith noted our current budgetary status and future plans. I'll add that the military health system is not unique in the year-to-year variability associated with predicting healthcare costs. COVID-19 has only exacerbated these known challenges. Nonetheless, we remain vigilant about our medical expenditures, and we appreciate that Congress continues to grant the department carryover authority, allowing the DoD to maintain better funding flows to minimize disruption of healthcare services to our beneficiaries. I'm grateful for the opportunity to represent the men and women of the Defense Health Agency, and I thank you for inviting me here today. I look forward to your questions.
Thank you, General Place. General Dingle.
Chairman Tester, Vice Chairman Shelby, and distinguished members of the subcommittee, thank you for the opportunity to speak to you on behalf of the Army's soldiers, civilians, and their families about the Defense Health Program. As the 45th Army Surgeon General, my promise to you, our soldiers and family members, is that we will remain good stewards of the DHP and will always be ready to answer our nation's call. Today, our Army's medical force is ready to deploy today, fight tonight, and return them to duty tomorrow as we provide world-class health care to over 146,000 forward deployed U.S. Army soldiers around the globe. The Army's ready medical force will provide evolving health care to meet the demands of the warfighter in any operational environment. My strategy to provide a trained and ready medical force while remaining a good steward of the DHP consists of 5 objectives. We will synchronize and integrate the medical effort within the Department of the Army, the Defense Health Agency, the Joint Staff, and combatant commands to ensure responsive and relevancy as we execute the National Defense Strategy. We will build readiness through investments in our human capital, people first. Our healthcare professionals have demonstrated their dedication and readiness in response to the global pandemic for the last 2 years. We must be innovative and judicious to remain competitive with national healthcare industries to recruit and retain our best medical professionals. We must monitor the impacts of the prolonged pandemic response on our healthcare workforce, our soldiers, and our families. Suicide and stress harms our most valuable resource, our people. One suicide is too many, and we will continue to combat it at every level to get ahead. We will modernize the medical force. Modernization is occurring in near term as Army aviation expands future vertical lift and future long-range assault aircraft. In parallel, we are developing a medical variant. Army medicine will not be left behind. We will medically reform. We are transforming in accordance with legislation and the department guidelines. The Army has completed or programmed resource transfers of more than $22 billion of the DHP and over 32,000 civilians to the DHA. Focused on readiness, our regional health commands will reflag to medical readiness commands this fall. Finally, we will strengthen alliances and partnerships. I have reestablished liaison roles in support of our NATO and partner medical groups. The cohesion ensures combined forces medical readiness in a globally integrated environment. In closing, I want to thank the subcommittee for your long-standing support to the Army and Army medicine. Our trained and ready medical force depends on timely, adequate, predictable, and sustainable funding. With your continued support, Army medicine from the foxhole to the fixed facility will in fact remain trained and ready. Army medicine is Army strong. I look forward to the subcommittee questions. Thank you.
Thank you, General Dingle. General Miller.
Good morning, Chairman Tester, Vice Chairman Shelby, and distinguished members of the subcommittee. It's an honor and a privilege to appear before you today as the Surgeon General of the Air Force and Space Force to provide an update on the Air Force Medical Service and discuss my vision and priorities. I appreciate the committee's longstanding support to include the fiscal year 2022 omnibus that provided much-needed additional resources to the department. I also want to take the opportunity to recognize and thank the outstanding professionals who chose to serve in the Air Force Medical Service, which we call the AFMS. Since its creation in 1949, the AFMS has continued to provide leadership in aerospace medicine developments, aeromedical evacuation capabilities, emerging military operations, and recently, the U.S. COVID-19 response efforts. The AFMS team has and will continue to serve the nation as we fly, fight, and win. The Air and Space Forces are inextricably linked in defense of our nation. The AFMS provides ready medics to ensure airmen and guardians are medically ready to defend the crucial high ground in a rapidly shifting global security landscape. Over the past year, we faced unprecedented simultaneous challenges from responding to the COVID-19 pandemic to finalizing the transition of Air Force military medical treatment facilities to the Defense Health Agency. I know my DHA colleagues will provide more detail on the transformation. I can report, however, that we continue to be an all-in partner with the DHA. In fact, more than 80% of uniformed AFMS medics work and train in military medical facilities, which serve as one of our key readiness training platforms. It is critical we maintain a strong partnership with DHA to ensure the military health system continues to sustain this vital source for clinical training and currency for the AFMS. Although MTS are not our only readiness platform, they are certainly our preferred platform in the AFMS. The 21st century is reaffirming the world is not a safe and tranquil environment. Beyond the pandemic aftermath, we face national security challenges from the Russian Federation, the People's Republic of China, the vulnerabilities of proliferated technology and weapons, climate change, and continued conflicts, old and new. The medical system, specifically the AFMS, more than ever, must be bold, resilient, and above all else ready for a fight tonight, tomorrow, and beyond. Our vision is to ensure we are the world's elite medical service in air and space. The reality we know is the future fight will not be like what we have seen in the past. The next fight requires us to evolve now. We need your support to modernize our key readiness capabilities, properly equip our medics, and ensure the Air Force and Space Force remain ready fighting forces. With this in mind, I want to focus on three things. First, my vision and priorities. Second, America's return on investment from your current support. And third, the need to create more resilient medics and training platforms while being an optimal steward of taxpayers' resources. As we know all too well, the world is not static. New diseases emerge unexpectedly, chemical, radiological, nuclear, and bioterrorism threats persist, and combat weapons are deadlier. In future conflicts, we cannot assume we will have the upper hand. However, America is in an era of great scientific opportunity. Advances in our understanding of human biology, digitization, communications, and artificial intelligence will enable Air Force medics to accelerate change and win. We are in a race against economic and human consequences of national security and disease, yet we are on the brink of transforming AFMS medical readiness capability and capacity. Included in the testimony is the AFMS strategy map, which I will briefly go over now. In short, my priorities are to first, generate high-performing airmen and guardians by prioritizing training, maximizing medical availability, and optimizing human performance. Second, enhance joint and combatant commander capabilities by increasing the agility of patient movement, improving the medical supply chain, and increasing global health engagements. And third, maximize human capital and strategic resources by breaking down barriers of inequity, incorporating policies focused on diversity and inclusion, and equipping airmen to evolve for tomorrow's fight. Toward these goals, the AFMS is reimagining the design and future of our readiness capabilities, such as air medical evacuation and critical air transport teams. We must build on past successes, but be willing to break the cultural norm that says things have always been done this way. We are exploring and challenging our previous decisions about the size and types of clinical teams and how to best train and sustain their skills. We believe innovation and fresh ideas will enable us to be more resilient and expand these teams' capacities within the current AFMS end strength total. Future conflicts may see medics needing to hold and treat patients in deployed settings for longer periods than in the past. We are actively evaluating how our teams can remain agile and leverage technology to provide trusted care anytime, anywhere. To respect the committee's time considerations and ensure time for any questions, I ask to submit my remaining comments into the record. In closing, it is an honor to have this opportunity to be here today. Thank you for your continued support of the Air Force Medical Service. Your future investments will ensure we may remain prepared for tomorrow's fight. Thank you.
Thank you, General Miller, and I didn't say this at the beginning, but your entire written statement will be a part of the record, so thank you. Admiral Gillingham, you're up.
Chairman Tester, Vice Chairman Shelby, distinguished members of the subcommittee, I'm pleased to be with you today to provide ability to quickly deploy and support crisis response around the world makes military medicine unique, but more important, demands that we are both operationally relevant and clinically prepared. Again, thank you for your leadership, and I look forward to your questions.
Thank you, Admiral Gillingham, and I want to thank you all for your testimony. I'm going to start with some questions that revolve around mental health, and they're for you, Dr. Smith. We've seen the rate of suicide rise upon military members over the last 5 years. I would say significantly. We could blame that on a lot of things, on COVID, on economic strain. There's a lot of pressures out there. The question is for you is that what programs and strategies is the department using to reverse this alarming rate of suicide amongst military members?
Thank you, Senator Tester. We agree with you that it is an alarming rate, and any suicide is clearly a tragedy. We're using a public health approach, recognizing that medical is one component, but that there are clearly requirements across the force to be able to try to tackle this. And suicide clearly is a multifactorial in our examination, and I think most would affirm there are many different factors that go into it, as you've already recognized in your comments. But we have a number of different pieces going on, encouraging help-seeking behavior, looking at stigmatizing language throughout our policies, clearly increasing access to mental health with telehealth. We also have made sure that all of our providers are trained in cognitive behavioral therapy, which is one of the modalities that has clearly been shown in randomized trials to be helpful in suicide. But we know that it is an all-hands priority for our secretary and something that all the members of this panel have been actively engaged in.
And so the policies that you put forth to deal with mental health, are they measurable, and are you measuring them?
Yes, sir, we are, particularly looking at access to make sure that we have ready access to that. We also, as you're probably aware, screen our folks with our PHA, also with our before they deploy and after they deploy. But from an access point of view, we are challenged like the rest of the nation, but we have a standard that they need to be seen within 28 days. We're running at about, for active duty, 11 to 13 days for their initial appointment. Okay. And then for follow-up appointments, it's variable, but on average, it's about 15 to 17 days.
Right. So, and thank you. I will tell you that now I want to go in a little bit different direction. These are the folks getting out of service. I think we have an obligation to the folks who serve in the military to make sure that that transition is occurring, is done successfully, and we're seeing, once again, suicide being a huge problem with transitioning from military to the civilian life. Part of there was a DoD report that came out of November 2021. You probably know what it said. It said that 70% of transitioning service members are receiving a required physical examination upon separation, physical examination, and that exam does not include any mental health screening. Only 5 questions were asked about mental health history with no follow-up questions. So, Dr. Smith, what's the DoD doing to ensure that 100% of transitioning service members receive the physical examination prior to their military separation? And while you're on that, what are we doing to make sure that mental health is addressed in that separation?
Yes, sir. The separation health physical exams have been a targeted focus. We've been working closely with the with the VA also in this to make sure that there is a warm handoff, if you will, for anyone that is known or recognized whether it's with that separation health physical exam or it is, they are already in our care. Each of our components have been working to try to improve that. We've also just recently revised the policy, and it's in the process to further assure on the separation health physical exam. But I'll defer to some of my other teammates to see what additional comments they'd like to make relative to that.
So I'm out of time on that. If any of the other folks, the Surgeon Generals, want to respond to that in writing, I would appreciate it if you could. I just have one more, and I know I'm over time, but I've got to follow up on this. Mental health, I've been here 15 years. We've been talking about mental health for 15 years on the VA committee. These are folks who are coming out of the military, and they're killing themselves, okay? The mental health component was not a part of the evaluation that's being done. Only 70% of the folks are doing the evaluation to begin with. And now, once the IG report comes out, and I think it was November of 2021, now it's going to take until 2 years, November of 2023, before it includes mental health screening. Now, I understand it takes a while for government to do stuff, and it's tough to get the ship turned around. But I would just say this, if mental health is a huge issue, and it is, and you guys all know it, most of all of you addressed it in your opening statement, why are we tolerating the mental health screening to take 2 years to get into the transition?
Sir, I will take that for the record because it's my understanding that we have mental health screening questions as part of that examination. So I will take that back and provide
Okay.
an information.
There are 5 questions now. There are no follow-up questions even, and they deal all with family history, is my understanding. But I would just say that I can tell you if Moran was here, he'd say this. He's on the VA committee with me. He's ranking member. And we got a huge problem. We've got a problem with the fighting force to begin with, as we pointed out with the first question. And we've got as big or bigger problem when they're transitioning out of the military. I think it's a bigger problem, actually. And so we need to get this right, and we need to get it done right soon. So I appreciate your attention to this matter. Senator Shelby.
Thank you, Mr. Chairman. General Place and Dr. Smith, I'll direct this to you. Medical care costs are continuing to increase year after year, as we all know. The medical community says it's already preparing for the next pandemic, which you need to do. The Biden administration's military health system requests for $54 billion. With major supply chains affecting pharmaceuticals and inflation at an all-time high, can you tell me what the department and the DHA are doing to help find cost effectiveness, if you can do it, within the military health budget, considering all of the above? Dr. Smith. That's a tough question to answer. I know it is.
Yes, sir. I will start. I think we have been, and I'll defer to General Place on the specifics, but because of the consolidation, we've been able to do more with standardization. In the pharmaceutical area, as an example, we've been taking advantage of our ability to, our size, along with the VA, to be able to keep those costs in check as much as possible. But we're continually looking at our logistics chain and our other aspects of how can we, maintain our effectiveness but increase our efficiency. And a lot of that, I believe, is standardization, larger buying power, et cetera. But I'll defer to General Place.
Yes, sir, I'll agree with that. So it's pharmacy, it's equipment, it's supplies, it's personnel contracts, it's all of them being more efficient. But even more than that, when you narrow it down to fewer options, then the the requirement to maintain them is also less. Because we have fewer options, the patient safety events are also less. Therefore, we're not paying for harm that we're causing because of it. So it's a huge amalgamation of the standardization effectiveness drill that we do.
I'll direct this to each of the Surgeon Generals. Now that the administration has completed its national defense strategy, would each of the Surgeon Generals speak to what their respective services are doing to adapt, to innovate, and modernize their medical service capabilities to respond to the current and the future needs of the combatant commands?
Senator Shelby, I'll start off. Within the Army, the one mandate we have is to provide trained and ready forces. And so as we look forward into the future and modernization, we are focusing our strategy on maximizing human potential, pushing medical capabilities far forward, providing robotic, semi-autonomous support systems, medical command and control systems, the medical information management, biosurveillance, biodefense, medical operations, and I could go on and on. The key point is that as modernization occurs, Army medicine is not going to be left behind. We are inculcated tightly with our Army Futures Command, and I know that there's some concern about research and development transitioning. It's our expectation that the Army strategy to ensure force health protection and conservation of soldiers on the battlefield will remain that same research priority as we transition. But we're very active to include an Arctic strategy in which Army medicine conserving that fighting strength in support of any strategy that comes out of the Army.
Thank you. Yes, sir.
Vice Chairman Shelby, Air Force medicine is equally concerned about the requirements and how to best support the warfighters from the various combatant commands. Our niche, obviously, is air and space medicine. And so we know that a lot of emphasis needs to go on those domains. In particular, I'd say aeromedical evacuation and en route care is one area that we will continue to emphasize. Our CCAT, critical care air transport capability, and other ways of moving patients as need be will continue to evolve and be a challenge. In addition, the experience of COVID and these last few years have made us want to relook at our readiness structure, and so we are taking a hard scrub of our present team composition to make sure that we stand ready based on the requirements that are given us moving forward.
Yes, sir.
Yeah, thank you, Senator Shelby. As I said in my opening statement, in the Navy and the Marine Corps, we're moving to concept of operation of distributed maritime operations, expeditionary advanced basing operations, and littoral operations in a contested environment. And so we are actively involved in adapting our medical capabilities to provide medical power for naval superiority in those environments. The support that this committee has provided specifically with regard to the expeditionary fast transport will be very helpful in that, and that helps us be able to provide a float roll to surgical and medical care in that environment.
Recently, it's been noted that cybersecurity is one of the top concerns across the department. Is the agency anticipating increases to cybersecurity costs? Because I think that's something you have to deal with. Who wants to deal with that? Sir? Yes,
Yeah,
sir.
Senator Shelby, I'll handle that. So cybersecurity and the medical network is my responsibility. We are effectively funded for cybersecurity now. One of the benefits of the investments that you all have made in our next generation electronic health record, MHS Genesis, decreases our virtual footprint, therefore making it harder for potential adversaries to get into our network. So no, we're good for now. The fact that we are shrinking our footprint makes us a less vulnerable target even in the future.
Senator Baldwin.
Thank you, Mr. Chairman. In 2016, the Jason Simkowski Memorial and Promise Act was signed into law. I authored that bill in response to a tragic and preventable death of a veteran at the Toma VA Hospital in Wisconsin. Among other things, this legislation helped strengthen oversight of VA opioid prescribing practices, and improved our investment in non-opioid pain management techniques to help our veterans. And I'm pleased to report that the VA opioid prescribing practices now adhere much more closely to the CDC guidelines. Dr. Smith, a 2020 Department of Defense Inspector General report found that the Department of Defense had a lot of work yet to do in its management and oversight of prescribing practices and in ensuring that providers were working within the CDC guidelines. At the time, the Department of Defense did not have an effective way of monitoring prescribing rates, something that is supposed to be addressed particularly or partially by the new electronic health record system, which is not fully implemented yet. Can you update us on current prescribing rates compared to previous years? And can you inform us how you are monitoring prescribing rates now and how the department is prioritizing non-opioid first courses of action for pain management, such as holistic therapies?
Yes, Senator Baldwin, we consider obviously pain management and opioid safety to be a critically important part of our practice. And as you're probably aware, the military health system has instituted a stepped care model, which actually looks at alternatives and very consistent with what CDC recommends, along with working with the VA in partnership with our CPGs around this area. We also require opioid prescriber safety training for anyone who is credentialed or privileged to be able to provide opioids. And we are now have our prescription drug monitoring program, which allows us to interface with states and to be able to share information on what individuals may have been prescribed. And it's now up to 29 states, if I remember my numbers correctly. And we also know that it's in the active duty force, it's now about 0.07% of the active duty. And we find that with our opioid prescribing, that less than 1% actually run into issues compared to somewhere between 8 to 12% outside the DoD. Specifically, how we're monitoring the practice of our individuals, I will either defer to General Place or take that one for the record to make sure that I give you the right information on that.
Go ahead, General.
Yes, Senator Baldwin. The first thing we do is within the pharmacy itself, we monitor every single one of our prescribers who have the authority to prescribe scheduled medications. And secondarily, as Dr. Smith mentioned, when it comes to ongoing on-site credentialing and privileging, the number of scheduled medications, not just opioids, but scheduled medications that are prescribed is one of the things that's evaluated in the reapplication for clinical privileges. Secondarily, we've added safety nets to those patients that our providers believe are at risk. There's naloxone therapy, and that's a first-step therapy that goes with opioid. But in addition to that, we've given the authority to our pharmacists for those that they consider at risk for opioids to have the ability to use naloxone. And then finally, you mentioned in your introductory comments about the non-prescription methodologies for pain control. We continue to evaluate all aspects of it: yoga, massage, chiropractor, acupuncture, et cetera, for the state of the science for the potential of making those TRICARE eligible therapies, but only with science behind it. And so we're continuing to do all that.
Thank you. Dr. Smith, as the department knows, the National Guard has become an increasingly integral part of our total force. But according to the National Guard, over 66,000 Guard members are uninsured. roughly 16% of the Guard. Many of these individuals are students who are at risk and in need of mental health services and resources. I'm sure that you would agree that if 16% of the active duty service members lacked access to quality health care, it would present a serious readiness issue for the department. Would you agree that this is critical that all National Guard members have health care coverage and that it is important as a part of our total force that we should consider this a readiness issue as it affects the Guard?
We do think that healthcare coverage is an important issue for the total force, absolutely. We do offer for the National Guard, as you're probably aware, TRICARE Reserve Select. It is substantially underwritten by the government, but there is a premium associated with that. The uptake rate is not as high as we would like, and clearly we continue to try to educate, but as you know, young individuals often consider themselves invincible, so making that case can be challenging. But that is what, at this present time, we offer. And then, of course, when they come on active duty, they're eligible for the full TRICARE benefit. So I hope that answers your question.
Senator Collins.
Thank you, Mr. Chairman. I want to follow up on the question that Senator Baldwin just asked. Maine National Guard members have told me that there is a need to extend TRICARE Reserve Select at no cost to the Guard members who do not currently qualify for premium-free TRICARE. And one of the concerns that has been raised is that service members have to change health care plans when individual duty status or orders change, and that affects continuity of care. Given that National Guard members need to maintain medical deployability requirements, ensuring consistent and reliable health care for all of our National Guard members is indeed a readiness issue, as Senator Baldwin said. And as an example of that, we're soon going to see a large group of Maine Army National Guard members deployed to Poland. So do you see benefits to medical readiness that we might expect by extending this TRICARE eligibility for these Guard members?
Yes, ma'am. I think there are pros and cons to that, obviously. I clearly would think having TRICARE Reserve Select, essentially the TRICARE program for our National Guard, should facilitate medical readiness. On the con side would be there is a substantial cost associated with expanding the TRICARE benefit to the National Guard. Also, we have to be cognizant of the fact that of how that may affect ability to recruit and retain active duty versus reserve and Guard as we sort of equalize the benefits that are accrued with that employment as another potential side effect of expanding the program to the entire National Guard. Over.
If you could provide us with current budget estimates for the record, that would be very helpful to us. My second question, which is for General Dingle, follows up on the excellent concerns and questions that our chairman raised, which I very much share, about the rate of suicides and other mental health challenges facing some of our service members. I was surprised to see that the number of behavioral health encounters actually fell from 2.05 million in fiscal year 2020 to 1.68 million in fiscal year 2021. And yet suicide numbers remain very consistently high. So I'd like to ask you, General, to elaborate on the factors so that I can better evaluate this declining statistic, because it does not seem to be correlating with a similarly substantial decline in suicides, for example. So my questions are, were there fewer behavioral health patients? Were there medical staffing challenges that you mentioned as an issue? Or was Army medicine unable to facilitate certain visits due to facility closures or other complications that perhaps are related to the pandemic, even though we saw an uptake in telehealth encounters, which I think was very valuable? Could you elaborate further on the factors for that decline?
You know, Senator, that is a great question that I do not know the exact answer to. As we look at it across the board and across the United States Army, one of the things that we're trying to get across is, one, to remove the stigma so that our soldiers will in fact seek behavioral mental health, that it is okay. And so we've implemented several programs at the strategic, operational, and tactical level to get after that. In some cases, some areas, we have programs like Operation Victory Wellness or Mission 100, which every soldier must see a mental behavioral health provider within that year's time frame, one, to ensure that their needs are being addressed. We also have a major campaign throughout the Army. At the strategic level, we have spiritual readiness initiative, leveraging our chaplains to help make soldiers feel at ease that they can access care, increase in the MIFLIX, increase in that access to care with the mental behavioral health that are in our medical treatment facilities, the MIFLIX, and then our spiritual readiness initiative. Again, selling that it is okay to get help. In addition to that, Commander's Risk Reduction Tool, this is my squad golden triangle that every soldier is a battle to a soldier, and it's okay to help and identify when someone's in need. And then, again, at the operational level in our divisions and corps, many programs that, again, mandate a touch point, yet also in conjunction with DHA, leveraging behavioral telehealth. Interesting, I'll close with this. I just came from Alaska. And in Alaska, the behavioral health, the telehealth went down. Everywhere else is skyrocketing and couldn't figure it out. After talking to family members and soldiers, the soldiers said this. They said, you know, General Dingle, we don't want to talk to a television. We would rather wait, for access to care. And when it came to the family members, that's some things we're working with the DHA for hirings to get after the family members, but the soldiers and service members were able to support. But we are actively, aggressively trying to attack that, Senator.
General, did you want to add something? Or am I misreading your body language there? I'm really interested, if the chairman will indulge me in just 30 seconds more, in what you just said about telehealth, because our experience in Maine has been exactly the opposite. What we've found is that telehealth counseling reduces the stigma. And as one hospital administrator told me, when they moved all of their behavioral health sessions to telemedicine during the pandemic, their no-show rate went to zero. And what I've also heard from others in the VA is what they do is they will call someone if they don't show up and find that they can do the counseling that way, and thus they've driven down the no-show rate. So maybe this is an anomaly with Alaska, because it seems at odds with the experience that I'm seeing in Maine and hearing from healthcare professionals that our veterans and our service members don't want. It's sad that there is a stigma, but they don't want to be seen going into a psychiatrist, psychologist, social worker's office. But if it's done, they're very comfortable with video conferences. So that's really interesting that you found the opposite in Alaska.
Yes, ma'am, and let me clarify. The one thing that the family members and soldiers were saying, it wasn't the attribution to the stigma in Alaska so much. It was more so the 24 hours of darkness, the cold weather, where they're in a cocoon, you know, and so they're in a cocoon so much that for them to do a behavioral health, they're like, no, via telehealth, they said, we would rather wait, and I want to see Dr. Lyons or Dr. Jones in person versus talking over a telephone, which was their preference, which is where we're trying to educate them on the benefits of the virtual platform in the meantime until getting a person-to-person.
Thank you. That's a good point. Thank you very much.
No, I think it's a good point, and these folks were being dealt with on the telephone and not by video.
Video. You leverage both platforms.
Okay.
We use telephone, video.
The information I've gotten is exactly the same as Senator Collins. That it's actually less threatening. And by the way, I would have never thought that. The very first hearing I had, when they said to use telehealth, I said it'll never work. I am going to ask a couple more questions, so if you want to stick around, you sure can. These questions are for General Place, and then with a follow-up for General Dingle. Currently, most defense medical research is done by the Army's Medical Research and Development Command. The FY19 NDAA required that all medical research be consolidated under the DHA by October 1 of this year. Besides the core medical R&D efforts, the consolidation of medical research under the DHA would include congressionally directed medical research program. Congress is concerned that there is no disruption in the CDMRP process. So, General Place, please give us an update on the status of required consolidation of medical research under DHA.
Yes, sir. So thanks for the question. It is on track. We are in close collaboration between not just the Defense Health Agency and Army's Medical Research and Development Command, but across all three of the services to transition all aspects required under that law done this fiscal year with very warm collaboration between all of us such that no disruption in the Congressional Designated Research Program will happen. I think we'll all assure you that that's our motivation and we'll attest to that.
Okay, and the consolidation is happening in a way that would reflect your statement that you just made.
Yes, sir.
Okay. Do you plan on making any changes to the congressionally directed research once these efforts of transferring are totally made to DHA?
We have no plans to make any changes to it, Senator.
So from your perspective, General Dingle, I recently visited the U.S. Army Medical Research and Development Command at Fort Detrick. How do you envision supporting the Army's mission for research and development to prevent or treat current threats to our soldiers while the medical research and development assets and infrastructure are moved to DHA?
And so, Senator, we believe that there will be no change. As close as we are working together with this transition, we anticipate as the DHA consolidates the research across the services, that each of the services' strategies and priorities will be inculcated under one umbrella. At the same time, as you know, we take great pride in CDRMP. And as General Place just said, they have promised and have put in the way ahead that no changes will be made. So we're anticipating the best practices will be maintained, which includes a consolidation of each of our priorities when it comes to research and development.
Thank you. Before I turn it over to Senator Moran, I want to make a statement. If you guys want to respond to it, you can. I'm chairman of the VA committee. We're working on toxic exposure. It's a huge issue because, number one, there are inaccurate records of exposure as folks come out of the military. The toxic exposure issue is huge and will end up costing, if we do the right thing, hundreds of billions of dollars. There's just no doubt about it. This isn't the first time we've been at this rodeo. We had mustard gas, we've had radiation, we've had Agent Orange, and now we have toxic exposure with burn pits. I hope that this is on your guys' radar so that we can figure out how to do better moving forward. What's done is done. Why we had burn pits and not incinerators will be a mystery to me because it seems like an unnecessary harm that we've inflicted on our service members. So hopefully this is on your guys' radar screen so that we can do better. I would love to say we'll never have another conflict, but the way Putin's acting, it's hard to say that. And so there will be another toxic exposure issue that's going to come down the pipe. And if we have good record keeping, it could end up being a lot better for everybody.
Yes, sir. We wholeheartedly endorse what you're saying. Clearly, it is high on our radar, and we are continually looking at mechanisms to improve. We, as you're probably aware, have created the ILR, the individual longitudinal exposure record that both we and the VA have access to. It consolidates and all of the information that has been collected relative to where I have been during my career and will be readily available and is now at the point where that information has been uploaded and is available. The features that are coming on now is, which is very exciting from a research point of view, is we're going to be able to look by exposure and develop cohorts to help our development relative to ILR. We've also put into the PHA and the PDHRA and the various screenings that we have questions to probe and find out about exposures that folks may have had to be able to document that. The long pole still is being able to do individual exposure monitoring. It's all area monitoring. We clearly are concentrating on getting the right training and the folks available to be able to do that. But our research and development side is looking at how can we better, through wearables and other kinds of technology, be able to do exactly what you're suggesting of having a much better idea of exposures. Now, war, of course, is unpredictable.
Yeah.
And, but I think it's clearly top on our list of priorities.
All right, thank you. Senator Moran.
Chairman, thank you. I came back to ask questions that you apparently have already asked, but maybe I can be more articulate than you were.
That's always the case.
First of all, thank you all for your service and for being here. Just in a comment back to Dr. Smith, the individual longitudinal exposure record does not get high marks from those who are experiencing toxic exposure as far as the records being accurate or available. We find veteran after veteran who says there's nothing in their record that indicates exposure during service. And maybe that's just a matter of catching up in time, I don't know, but it has, it apparently needs more attention than it has received. And I understand in my absence that the chairman, my chairman here and my chairman in Veterans Committee has asked about the discussion we had regarding the November 2021 report evaluating the Department of Defense's implementation of suicide prevention resources and in its following its compliance with Executive Order 13822 regarding mental health. And if these questions have been asked, I just would add my agreement with what I assume the chairman's point was, that there needs to be greater progress at the department in implementing the Inspector General's report, and maybe you've answered that question. What are the barriers that have been identified at DoD's ability to provide seamless transition for mental health care services to those service members already enrolled in mental health care? and what changes, either administrative or legislatively, need to be put in place in order to make all transitioning service members receiving a mental health screening before leaving the service. If you've answered that, Dr. Smith, you can tell me just to refer to the record and to the chairman's questions.
Well, we partially answered that question. We are actively engaged with anyone that has already is in our system with the VA to make sure that there is a warm transfer, if you will, that they're aware of the case, that the individual is aware of how they can access the VA. We also have, as Senator Tester and I discussed, there are questions in that in the SHPE, the Separation Health Physical Examination, that tries to address mental health, really as a screening, and then, of course, as a provider, if there are flags that come from those questions, then our expectation and what I think happens is that they will get a follow-up in reference to that. But that's, I don't know if anyone else wants to add to my response, but that's.
So I think I'm hearing you saying that you think the things that are that need to be done are being done.
We are working on it. I think there's always more we can do, and I don't think that it's at all perfect. But there's clearly a prioritization on the importance of that transition. And we have been fine-tuning it, if you will, across our policies relative to all the different elements of the total force also, to include guard, reserves, to make sure that that is a warm handoff. But I recognize there are still drop balls.
In almost every instance in which we've looked at, in the Veterans Committee have looked at veteran suicide, it is that transition period of time in which the vulnerabilities are the greatest. So I encourage you to pay significant attention and keep trying to eliminate whatever flaws still exist. Let me ask General Dingle, I want to talk about in ICO, I think there's a total of 8 sites on military bases that treat service members with the effects of traumatic brain injury, behavioral health, and other conditions with a broad range of innovative and emerging treatments and therapies. This is the National Intrepid Center for Excellence, As the Army and Intrepid Fallen Heroes Fund looks to establish additional sites on military bases, is there any reason why Fort Riley would not be on a short list, especially with the Warrior Transition Unit and veteran population that could benefit from a joint VA-DoD site to serve both populations? And I'd be interested in knowing if there's something, which I don't expect you necessarily to be able to answer that question at the moment, but if there could be follow-up, if there's something missing at Fort Riley that would enhance their chances of being able to treat their soldiers and veterans, I'd be delighted and very interested in knowing, General.
Okay.
Yeah, Senator, if I could take that one. The responsibility for all the Intrepid Spirit Centers is now within the Defense Health Agency.
Okay.
And it is largely, as you've already indicated, in the troop concentration centers that in our interaction with the Intrepid Fallen Heroes Foundation, that the sites have been funded by the foundation, and then we man them and organize and utilize them later. I'm not aware of where potential for Fort Riley is, but as a major troop concentration for the Army, certainly would be on the list. I'd be happy to engage with you and your staff further about where that might be.
That's a perfect answer. Thank you very much.
Yes, sir. Chairman,
thank you.
Thank you, Senator Moran, for those very important and articulate questions. Look, we appreciate your testimony here today. Senators may submit additional questions, and I will have a few. And we ask to respond to them within a reasonable time. I think a reasonable time is probably 10 days or sooner, if you could. The Defense Subcommittee will reconvene on Tuesday, April 26th at 10 a.m. for a classified hearing on Missile Defense Agency. I will recess by saying thank you, folks, for all your work. It is very, very important work. And also know that the work that you guys do, dealing with active military and transition and mental health and all the other things that you've talked about in your opening statements and during the questions and answers, is not only important for our military, but it's important for our country overall, because you guys lead the charge on medical research issues, and we thank you for that. With that, this subcommittee stands in recess.